Good evening, members, and welcome to our AAIP monthly treatment planning seminar. I hope that a lot of you were able to listen in. Was it last week? It seems like a long time. 2 weeks ago, when we had our video webinar. Jennifer and Dr. Sheldon did that one, and the next one that we have out, as far as the videos, will be on November 1st. That one is going to be on a Tuesday. It's our first Tuesday ever webinar, so please make note of that. It's only going to be for that month. We have to do it on a Tuesday. But that one will be on the video, which is the next step of the new patient experience, which is the doctor case presentation, where the doctor is giving the financial person the plan in front of the patient. And then for December, we'll do case presentation by the financial staff, which will be myself. So please tune into that. So today we are going to be doing our case presentation, but I think we're going to mix it up a little bit today because some good things happened this week. Some things happened that remind us what we should be talking about.
They do, because, we hear from you and find out what you're thinking, which, of course, makes a big difference to us, because we want to make sure we're giving you material that's actually going to be good and useful to you. There's some confusion and a little bit of fear out there, and I know that. And the reason you're members is because you want to get past that fear, and you want to have some good methods to get patients in, and you can get patients in, and we're going to go over some of that. But what happened this week was very interesting, because it reminded me somewhat of what it was like when we were getting referrals all the time. But it was a lot better. When a patient is referred from a general dentist, the patient is pre-sold. The patient walks in and is more likely to accept treatment. That's interesting. If we keep track of statistics, they're usually not as good as we think they are. But on the referral line, I've heard constantly people say, 90% of my patients accept treatment. And then I ask, do you keep your stats? And the answer is no. So it's important you keep your stats so you understand. But let's understand what your success really is. But what was very interesting was the number of patients that came in this week that were pre-sold. These were patients who came to us and they were unreferred, or at least unreferred by a doctor. Instead, they were referred by all of the things that we talk about here, and frankly deserve some review, because we haven't gone over public relations in several months, and there are lots of new members on, and even for the experienced members who have been with us for a long time, some information bears repeating, and that repetition has to do with the things that you do to create your public image, because the things that you do to create your public image can create a group of patients who come in who are even more dedicated to you before they ever walk in the door than those patients who are referred from referring doctors. And so that's what we found this week, and actually we find it lots, but it just happened to such a significant degree this week, where there was one gentleman who walked in who had checked out all of the things that you would check out, had contacted an implant doctor in Fort Lauderdale, which is about 150 miles away from us. And just by looking at all of the points that we have on our website and all of the other things that we do, then the patient just walked in and was ready to, and did plunk down, $50,000,
Yes.
and was just ready to go. And you see, you can do that too. We get the idea that because we're periodontists, we're specialists, and therefore we're dependent upon the general dentist, and therefore our reputation sometimes is dependent upon what the general dentist says about us. And that's true, but everybody here is building their reputation. And for the experienced people who've been in practice for 10, 20, 30 years, you've already built your reputation. And that reputation transcends your being a periodontist. People are coming in to see me. Listen, I've been a referral practice for most of my career. It's only 4 years ago that we went fully direct to patient. But the people who are coming into us are coming into us based upon the reputation that we had, or that I had, as a periodontist that went on since 1980. You've got that same reputation. So don't shortchange yourself. You are a dentist first, and I want you to think about yourself as a dentist first and as a periodontist second. Periodontists second from a business perspective. Dentist first from a business perspective. Periodontist first from a diagnosis and treatment planning perspective, because you can do it better than most, maybe better than all. The way you treat your patients and the way you save your patients' teeth, the way you save your patients' money, the way you're thinking about the patients first transcends just gums and implants. And you're creating that reputation every day. We're going to show you some examples of that. We'll talk a little bit about treatment planning, and we'll go over a case. But I want to give you some examples so that you can see all of the things that you can do. And I don't want you to be overwhelmed, particularly the newer people here. I don't want you to become overwhelmed by all of the things that we do, because I'm 66 years old and I've been doing a lot of things for a long time, but I did them one at a time. And you become old enough and you have a lot of things in place. Or you do them and you methodically look at what you can do to put in a single program, make sure that's in place. And it might take you a year, and then do the next program and put that in place and continue to run the first program. You can continue to do that and create a fantastic public relations image for yourself. So I prepared this little brief PowerPoint. Let's go over that first. And let's go back up to the beginning here. Okay, so how new patients find our office. The thing that seems to have the most impact these days is the magazine. That doesn't mean the internet isn't referring a lot of patients. It is. But the magazine seems to be the thing that people like right now, and we hear more about the magazine. Eleanor, my wife, is sending out between 3,000 and 4,000 magazines every week, and that's going out by every door direct mail. The magazines are created by Gilead, and it's a 16-page magazine. She's mailing these out at 17.5 cents per copy. And the more magazines we send out, the more patients we get in. Fewer magazines we send out, the fewer magazines we get in. We've decided that about 3,500, 4,000 is the right number that we want right now for the number of patients that we think we can handle and handle well. The magazines are also at Publix, and which is, for those of you who are not in this area, which is most of you, that's the big food store in this area, which I'm sure all of you who visit Florida already know that. It makes a big difference to be able to have that magazine, and the magazine provides a certain amount of credibility because we look good in the magazine. Obviously, it's an advertising piece that's more than an advertising piece. It's a substantial piece of material which patients get, which patients can keep, and it isn't unusual for a patient to have the magazine for 6 months or longer and have them come in.
Absolutely.
So that's number one. The second thing is the website. And we'll take a look at various parts of the website. There are different types of websites, and I know that there are standard website providers, and frankly, they do a good basic job, but it's a basic job. The website has to provide enough content and has to provide enough incentive for the patient to stop at your website, and call that phone number and make an appointment. That's the whole idea, because once they leave your website and they go to another website, what's the chance that they're coming back? So we want to make sure that website is attractive enough and has all of the features that allow a patient who is interested to become interactive with your website in order to be able to get that patient in. So yes, there's a new patient special. We've gone over, and I see $79 all over the country now.
Yeah,
That's so nice. I like that. Yeah. And book an appointment and make sure that somebody books an appointment. So the $79 books an appointment, but look at all of the other things that are involved with this. Number one, we involved ourselves each year. We involve ourselves in the Best of Brevard. That's done in Florida today. It's essentially an advertising campaign where people will vote, and they'll vote for people in different services. There are probably 40 different service, 50 services. We advertise in that. I mean, there are only two dentists running. We're running against each other, and as long as we make sure there's enough votes coming in for our side, we always win, and we always win. So we were voted best of Brevard for the fourth year in a row. The people in Brevard County don't know how that works. They just know we're best of Brevard, and people want to go to the best of Brevard. It certainly pays. The advertising campaign costs us something like $2,000, maybe $3,000. Certainly, we get that $2,000 or $3,000 back. But more importantly, you see best of Brevard, and here in this area, that makes a big difference. But I want to show you the other things that are here. Number one, if a person wants to see who I am before I walk in, the person can play this video, which is about six and a half minutes. You can have a video done like this of yourself too. It's a matter of hiring a videographer and writing a script. And if you're not good at writing a script, then you go to the videographer and ask who's good at writing scripts. And you'll meet with the scriptwriter. You'll tell the scriptwriter the ideas that you want. The scriptwriter will write it for you. Run it, and if you're not going to memorize it, which you're not, you can do it off a teleprompter. You can do just fine. Or what I did in this case, I just had somebody interview me off camera. And I just came up with the answers. They edited it, came up with the best answers, and made me look good. And in 6.5 minutes, people were able to see you before they ever walk into the office. But there's more to it than that. If we go a little bit farther, you'll notice the number of different ways in which one can interact. Okay, so we've got the live chat. You can see that right here. So ACE Chat, who was featured in last semester's materials, very inexpensive, and we have people coming in through the chat service every week.
This week.
Yeah. Essentially, they're good. They're on 12 hours a day, and they will chat with you and encourage you to call or chat with the patient. Encourage the patient to call the office, or not that they'll give the contact information, and we'll call the patient and the potential patient and get that patient in. But also, okay, maybe you're not. Don't want to do a TV show, but there might be other things you can do. But there are a number of TV shows that we did. We can put that on the air. We wrote a book. You could write a paper. Instead of book by Dr. Sheldon, it could be paper on dental implants by Dr. Smith. And click on there, and you can, and somebody can interact with that and download that free paper or that free booklet or whatever it is that you've written. Ceramic zirconiated dental implants. Okay, it's a niche marketing thing. It's not a big part of our practice, but the fact that we do that differentiates yourself. Ask Dr. Sheldon. People can ask a question of me. I can answer online and give them an answer. And then you're seeing the top of the emblem because we won Florida Best of Brevard. So here it is again, and that came from Florida today. We loaded it up to the website. So there are a number of things that you can do with your website to make it interactive, and that's what we encourage you to do.
There's really three parts in what I find, and I see new patients all day long with our Sheldon, and I talk with the patient about how they heard about us and what brought them to come in as part of what they want and what they need. And it always starts with PR. There was something with PR that started the whole thing. It was either the charitable giving campaign, it was Best of Brevard, a newspaper article that they read and they've held on to. There was some kind of PR that they're talking about. Then they got a marketing piece. They either got a magazine or the special. They searched the internet and found them. Google reviews, looked at all the stuff on his website. Then they have the PR and that marketing together on top of now they've called. They've spoke to our staff, which are trained to answer the phones. Excellent. excellent answer the phones. Dr. Sheldon has given them a call, and they're coming in, and we're giving them that experience. Those combined things is what makes it work, and you can't do really one without the other. It's just those three combined things, because these patients are investing a lot of money, and they're trusting us, and these get them to where they know this is the place and this is the time.
So let's go over Google reviews, and we're up to 101 Google reviews. You can get Google reviews, and those of you who've been with us during the Google review session, or if not, then just order one of our packages. Total Immersion package has it. How to get a Google review? I'll be happy to send you just that portion. Just send us an email if you don't have that information. Getting a Google review is extremely important. Getting 101 Google reviews is a big deal. In your area. As a matter of fact, Google, I understand from Sue Skipper, who's Bruce Edelstein's marketing person, the Google treats you a little bit differently after you get over 100 Google reviews. And certainly it's going to help your search engine optimization, meaning your name is going to show up more prominently when you get Google reviews. I know some people say, well, I get my Google reviews from DemandForce or from Reputation.com or from some other organization. They don't show up. Google reviews show up. And so it's important that we strive to get Google reviews, positive Google reviews. Even the patients who don't come in as a result because of Google reviews, and we'll show you the number of patients and how they come in because we keep track of that. Even those who don't come in directly as a result of Google reviews, they're all checking out your Google reviews, or nearly all of them, because they're checking out your website. They type in drleesheldon.com, or they type in periodontist, they type in dental implants, whatever they type in our area, and our name comes up, they're going to look at your Google reviews. And if you have Google reviews, more patients are going to come in with more Google reviews. So I can't encourage that enough. I took a sample 8 weeks of patients, okay? So each one of these columns is a week. And you'll see here the numbers of referrals that came in and where they came from. So the first line is doctor referrals. Notice we're not that strong on doctor referrals, are we? Now, there was a time when that number was 40, 50,
Oh,
60.
yes. Oh, yes.
But it's per month, and of course this is per week. But we go down to the second line. These are patients who refer to other patients. Okay, significant number. Staff, and we're encouraging our staff to refer more and more patients. And we're giving our staff incentives to do so. TV, I'm still on TV every once in a while, and so I don't run TV commercials, but I do have or I participate in a TV show that's run on one of the free cable stations. So every once in a while people come in as a result of that. Under internet, we've now divided up internet and our tracking into 4 different areas. Internet is general. If all we can get out of the patient is they came in off the internet and they won't tell us how, that qualifies as internet. Then next is internet reviews. So that's Google reviews. And we've got a few patients that came in as a result of Google reviews alone. Although, as I said, the Google reviews is influencing everything else. Internet search, where they're actually searching for me or searching for a service, that's this number here. Going directly to the website, that's this number here. We used to give implant lectures. We're not doing that lately. A book that they've received, that's one. Looking at our sign, a couple over an 8-week period of time. A friend referring, okay, significant number. Magazine rack, this is what is in Publix, and these are the numbers that we expect a week. Magazine mail, this is what Eleanor does, and she goes to the post office every week, and these are the numbers of patients that are coming in. Okay, phone book. Yeah, somebody's still coming in as a result of the phone book. Self-referred, so who knows how they heard about me, but they came in for whatever reason, self-referred. And then the question mark, and
The mysterious referral.
We've been able to reduce that question mark quite a bit. And so over an 8-week period of time, that means 31 free referrals came in. We didn't pay for that marketing at all. Now, 31 free referrals for many of you could be a significant 2 months. That's 15 referrals a month that came in, not doctor referred, because you see the doctor referred. I'm only talking about those that are featured in these yellow highlighted boxes. Here, 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 and here. Concentrate on one of them. Just look at one of them and decide what is the new campaign that you can do. Let's say Google reviews, because I think that's a place where some of us could really do a lot better. How are we going to get more Google reviews in, more positive Google reviews, and have a campaign, part of a staff meeting? The staff meeting strategy. At the staff meeting, strategize. How are you going to do it? If you need it, then we'll give you our sample piece of paper that we use and how we do the strategy. We'll be happy to email that out to you, so that you can see exactly what we do and what we're doing in our office. You don't have to do what we do. But if you put it there, if you decide this is our campaign, and you track it so that you're keeping track of the number of new Google reviews that are coming in every week, or maybe even every day, then you keep on looking at that number and you review that number at the beginning of each of your staff meetings, which should be weekly, by the way. Yes, I've got an opinion on that. Then if it's a track statistic, you're going to be able to make that statistic better.
What's interesting, and we don't have it shown here, but I think would actually make things a lot clearer for our members, is if you had underneath here the dollar amount that those referrals brought in.
Yeah.
Because the reason why we don't care too much about those doctor referrals anymore, not only because we don't have to deal with the ones we don't like, and we get to, of course, do so much more with our patients, but they didn't bring in the dollar amount that the one TV per se did. Like you do the what was it? I was looking at the magazine mail. Okay, well, the magazine rack doesn't look like a lot, but the reason why we keep doing it is because a very few amount of magazine racks that went out was a large dollar amount that those patients spent, and that's how we stat our marketing, is not only how many patients it brings in, but the dollar amount of those patients.
Good. So let's go over a case, because I promised you a case. Someone all got in the wrong order. What did I do wrong here? All right. So let's look at Adrian. Okay, take a look at Adrian. And here's Adrian's chief complaint. No, I'm not going to tell you Adrian's chief complaint. I'm going to tell you how Adrian got to our office. As a matter of fact, Danielle is going to tell you how Adrian got to our office.
Yes.
Because Adrian came as a result of Eve. And Eve, her sister.
Yes.
Yeah. Okay, so let's talk about that.
So Eve had actually come into our office, and the funny thing about this, which is a lot of what we do with our members, is really tearing apart these patients and how they come into the office. So the first thing that happened here was her sister scheduled a new patient appointment back in June, and she came in. She called, had a great phone call with Jennifer. She got the doctor phone call from Dr. Sheldon. She comes in. She had a new patient examination, and she was planned for $10,000 worth of treatment. But her sister, Eve, did not schedule right away. She had some personal things that she needed to take care of. She didn't want to schedule right away. So the financial coordinator, as we always do, they follow up with these patients, and she did that. So Eve went away for 3 months. For 3 months, she was not on our schedule, and so that to a lot of people that would mean a no acceptance. But if you have a good follow-up regimen in, then what happens is 3 months later, Eve is now ready to schedule treatment. So Eve comes in, and she accepts treatment, and she pays $10,000. So with Eve's experience of how she heard about us, talking with Jennifer for the new patient phone call, the doctor phone call, coming in, her experience here with a new patient appointment, the way we followed up with her to make sure she's taken care of, she told her mom and her sister, Adrian and her mom, you've got to come to that office. You guys have got to make an appointment there. You guys have got to go. So then they came to our office because we really wowed Eve after spending $10,000, still we wowed her, and here comes her sister. So it those refer that's what we experience a lot is you help these people that have been on dental care for so long, and they can't help but say really good things about you. So when her sister comes in, we go from the first sister was $10,000, the second sister was $29,000, and mom's $10,000. So right there,
We don't
that's
know what
huge.
mom's at. Mom
We
paid
you're Yes,
because Eve didn't have any money.
right,
Adrian didn't have any money.
correct.
But mom?
Mom's estimated at $10,000,
Okay.
but we haven't done that
All right.
one.
And so let's, well, we won't put the cart before the horse, although Danielle kind of gave it away a little bit. All right. So what do you see? And her complaint is, I want my smile back. And by the way, the other complaint is, I sing and air is escaping through the back of my mouth, and therefore I can't sing properly because it makes a noise. So that's her complaint. Let's look at it further. Okay, so we take a look at the teeth, and we see that the teeth are a bit jagged in the front, right? Okay, you see what this looks like here. And you get the impression that this person, that Adrian wears her teeth, that she grinds on her teeth a lot. There's another view of it. Okay, and you get the also the impression, particularly those who are into treatment planning, we have some students on the line now. Notice that, and we'll see this with the retracted view. Notice the teeth, tooth number 9 is wider than it is high. And you know, tooth number 9 is supposed to be about 10 to 11 millimeters long. It's supposed to be about 8 to 8.5 millimeters wide. We don't have that here. We have kind of a square-looking tooth, don't we? Okay, so now let's look at the retracted view, and you can see the same thing. You can see how short and squat these teeth are. But I also want you to look at the posterior, okay, and take a look, and you'll get the idea that perhaps there's a collapsed ridge, not collapsed, but a deficient ridge on the facial aspect on the upper right and the on the upper left side. Meaning that there would need to be some kind of ridge reconstruction in order to be able to create a solution for dental implants, if in fact dental implants was the solution they're choosing. Okay, so you got that. Anything else I can show you? It's about the same thing. You can see how much wear there is in the lower anterior teeth and the upper anterior teeth, and Adrian's about 42 years old. Okay, nothing new in that view. Okay, so let's look at the radiographs and let's see what else we see here. Okay, upper right side, you'll note the broken root tip. Not a lot of caries experience here. I will show you some things that may bother you a little bit, but okay. You'll notice an apical lucency right here. Rather large apical lucency. Let me highlight that a little bit. Fractured cusp on tooth number 19. We travel around the arch. I missed one, sorry. Healthy periodontally, not really periodontal pockets per se. Not a lot of caries experience. Missing teeth, though. So that's where she is from that perspective. Let's look at her from a dental perspective, or from a CT scan perspective. There are going to be a few things you notice. Let me enlarge this a little bit. And so as we go from tooth number 2 to tooth number 3, notice how the ridge collapses down. And you start to get an impression. Remember we saw how that ridge deficiency, or at least a hint of that ridge deficiency in the photographs. Now look, this is the buccal, and notice as we're going through the buccal how narrow that gets. And not very high either. We're right now in the number 5 area, and look at how high that is until you get the sinus. Well, you've got, what, almost 10 millimeters before you get to the sinus. Okay, we come across and notice ridge position and then canine position. So the canine is in its correct position, but it again emphasizes how narrow the ridge might be. We'll just scroll across. We'll go through the upper teeth, and notice you'll see the same thing going on the upper left side. Deficient ridge, both horizontally and vertically. And now we get to some molar teeth, which are pretty good. Next molar tooth, pretty good. Let's go down to the bottom. And we'll move over first to number 19. Actually, let's go to the number 18 area. Okay, and what are you seeing in the number 18 area? There's the nerve right there. I'll move it forward a little bit so we're not cheating too much. There's the nerve right there. Where are you going to put the implant? Okay, are you going to angle the implant like this? Probably not. We'll show you in the Anatomize software how that would not work. So number 19 is, just so you know, number 19 is going to be the first functional tooth we have, and there's your abscess on the distal root. Would you choose to keep that tooth and do endo and restore it, or would you choose to extract it and put in an implant? Good. Number 20 is okay. 21 is okay. 22 is okay. All the way across they're okay, except there's a great deal of incisal wear. Now we move over to tooth number 29, and that ridge is beautiful. Look at that ridge. Okay. Here's the mental foramen over here. We'll move forward, but just so you know, get an idea as where the nerve is. It's right there without even locating the nerve. You can see it. Okay, we've got all that distance there, which is what, 13 millimeters? Yeah, 13 millimeters, almost 14 millimeters, and we're not even close to the nerve yet. And the ridge width here is 10 millimeters. Anybody have any trouble putting an implant in there? Good. So now let's move to something else, and let's look at the Anatomize software. Now I set this up with dental implants. Okay, so we put the dental implant here, and we put the dental implant here. And if we look at that, we'll see that dental implant is quite a bit inside of where the canine tooth would be. So if we're going to put an implant in here where the bone is, even though we're on the edge of the buccal bone, I suppose we could angle that implant a little bit, but I hope you may agree with me that there's a great deal of deficiency there. In fact, you can see the deficiency here. Here's the canine tooth, and now it dips way in by the number 5 tooth. Now it comes out a little bit around the number 4 tooth, or where the number 4 implant would be, and there's where the number 3 tooth is. So you can see how much of a horizontal ridge deficiency there is. If we go to the other side, and we look at the number 12 area and the number 13 area, not as much of a deficiency, but certainly a deficiency here. And so if we're going to build and put an implant in here without doing ridge augmentation, we certainly might have to plan on ridge lap teeth in order to be able to restore those properly. Not going to be a great look. So I hope you and I are in agreement that, in fact, if we're going to put implants in there, we'd have to do substantial bone ridge augmentation and build out the facial bone in both the numbers 4, 5, and number 12 and 13 sites in order to be able to make this work and make this work properly. And I think we could all make a case that maybe some kind of a sinus lift would be necessary here in order to be able to accomplish good dental implant placement. Now, if we go down to the bottom, notice here's where the implant needs to be placed in order to be able to be in functional tooth number 15, and there's where your nerve is right here. Personally, I don't think I could place a good implant there, and I don't think it's going to be useful to the patient for me to put an implant there, no matter where I move it. I move it over here. There's still not much bone here. I don't need a second molar in most of my patients. Some of my patients may request it later on, but I'm restoring when I'm doing implant therapy to a first molar occlusion, not to a second molar occlusion. A second molar is often overkill for most patients. But in the number 19 area where we potentially could extract that tooth if we decided not to do endo, the ridge width is nice here. And so we can put an implant in here without any problem. And see, the nice thing here is by putting my implant in the Anatomouse software, the patient is seeing teeth, not dental implants. If we look at the number 29, plenty of bone, plenty of opportunity to place an implant on this side. Let's go back and let's look at something else. And then I want to go back to the most important thing, because frankly, this is the most important thing to the patient. They don't care where the dental implant posts are. They might care how much they cost, but they don't care where they are. They care about this kind of result. And remember, Adrian's whole thing was, I want to be able to smile again, and I don't want air to be escaping through my back teeth when I sing. That's what she wants. We've talked about this before. Patients only want four things. They want to be able to smile, they want to be able to chew, they don't want their mouths to stink, and they don't want to be in pain. That's what they want. So a patient sees this and now all of a sudden sees that there's an answer. But I want you to look at it again, and I want you to see what you think the answer might be. So let's go to the most important thing, the photograph. What do you want to do for this patient? She wants to smile, she wants to chew. And in her case, she doesn't want air to escape so that she can sing. And I want you to look at this as a crown and bridge case, not as an implant case. I want you to look at this as a full mouth restoration for this patient, not dental implants that can be placed in missing spaces. Now, yes, we're going to put implants in number 19 and 29. There's no question about that. But what can we do to make her look prettier? And are the anchors, meaning the teeth numbers 3 and 6 and 11 and 14, will those be suitable anchors for fixed bridge work? And can you make a case for doing either veneers or perhaps opening the bite and restoring the length of these front teeth and doing this as a full arch case rather than doing this as an implant case? Because the patient wants to smile and she wants to be able to chew, and she's already worn out her front teeth, and she's 42 years old. So while the implants could be done, if we were to do 2 implants and 2 crowns, 2 implants, 2 abutments, and 2 crowns on the right side, and the same thing on the left side, what's that? $10,000? $8,000? But then we have to add the ridge augmentation and sinus lift onto that. What's that going to be? Another $6,000 to $8,000 in order to be able to give her 4 teeth. What can we do on the upper arch to give her a whole arch of teeth? And won't that make the patient happier? And will that make the referring dentist or the dentist that you refer to happier? And I don't care really about making general dentists happy. I never did I?
No.
No. No.
But there are a lot of periodontists out there worried about that. So
yeah, I know.
And it does, because there was a handful of dentists that you didn't mind working with.
Exactly right. But in this case, we're doing the best for the patient, which is going to be best for the general dentist. And we're going to keep the patient out of surgery. And by the way, within a short period of time, all of these teeth can be prepped on the upper arch, and a nice heat process temporary fixed bridge can be placed, which is going to restore the bite. She's going to be able to smile, and she's going to be able to sing. Now, after that's done, then we might want to make a decision as to what we're going to do in here. Maybe, and I warned you of this in advance, so you have a big divot here. Food might get trapped in here. Or the teeth might be so thick in that area you won't be able to clean it very well. We might want to do a soft tissue graft or maybe even a hard tissue graft just to build out the poddock area a little bit so we can have teeth that will be okay, that won't be difficult to clean. But you know what? We can test this in the full arch prosthesis first, in the temporary prosthesis, and see. We can just look at it, make the full arch temporary prosthesis. You let me know whether this divot is getting in your way or not. If it gets in your way, we're going to do a graft first. If it doesn't get in your way, then you can complete your crown and bridge work. In the meantime, we're going to restore the lower arch the way we talked about with implants numbers 19 and 29. And yes, make sure she wears a night guard. And also warn her that, in fact, not only are her upper teeth worn, but her lower teeth are worn too. So unless she wears a night guard, we might very well be into the restoration business on the lower arch as well to recover what she's lost on the lower arch. But if she wears a night guard, maybe we can just keep the teeth as is. Okay, so essentially you're making upper and lower impressions, doing a bite registration. You'd make upper and lower impressions, do a face bow. You would open up the bite to give her a normal incisal edge length. You would study the maxillomandibular relationship, and if it applied, and it will in this case, then you have the possibility of making her a full arch prosthesis and working with the restorative dentist to tell the restorative dentist how you just sold the full arch crown and bridge case. And you know how you sold it? By looking at what the patient needed and by looking at that and letting the patient look at that.
And I can tell you from the financial aspect of it, what sells the case is, of course, the things that lead up to the new patient examination. But what helps me, because I've been selling cases with you for over 10 years, is when you go into that room, you sit down next to that patient and you say, what do you want? And I bet you're surprised a lot of times what they say. Every doctor that's listening today can look in this patient's mouth and tell her what she needs. But unless you know what she wants, you're not going to sell the case. So for her, it was the sound that it makes when air goes through those missing teeth, and she doesn't like the way that sound makes. It was that she wanted to improve the way that smile looked, not just fill the holes with some implants. So when you asked her that question, what did she tell you? When you said, what do you want, Adrian? What is it that you would like?
She said, I want to smile. And she said, I'll tell you, I don't like the farting noise that comes out between my teeth. That's essentially what she said. Okay, so we address what you need, and we can do that real quickly in a full arch temporary prosthesis. And whether my son is making it, which, I have those advantages, and, we're not making any secret about this. We are talking about creating the director of dentistry. The director of dentistry essentially is assessing the patient's needs and doing what may be a good solution for the patient.
Right.
And by the way, when they go back into FA, into financial arrangements, I'm telling Danielle, listen, we can do a ridge augmentation, sinus lift, it's going to be this number of units, it's going to be this amount of Miniros, this amount of Biowas, this number of membranes, number of implants, custom abutments, crowns, all that kind of stuff.
Right.
And then Danielle can say, all right, if we did it the implant way, it would cost this, and here's the downside and the upside. And she can say, if we do full arch crown and bridge, here's the downside and the upside. Which way do you want to go? Well, what do you think is better? Well, if we do the implants, it's probably going to take somewhere between 14 and 16 months to get it all done. If we do the ridge augmentation, followed by the implants, followed by the crowns. Patient says, oh, I can't wait that long.
And we say that, we have that discussion in front of her, kind of over her. We had that discussion. You know and I know what she wants because she's expressed it to both of us. I want a better smile. I want to fill those holes. And she wanted to have it now. She doesn't want to wait a year and a half to get done. She's singing now. She wants to have it done right now. So we know this. So she did come in for implants to fill the holes in the areas. So you do say to me, I can give you the implants. I can fill those areas with implants, but I'm going to have to do the ridge augmentation. I'm going to have to do the bone grafting. That's going to take 6 months to heal. Put in the implants, wait 6 months to heal. Then for restorative, we're talking about 18 months or so, or 12 to 18 months or so. So when she's hearing this, and then also I'm telling you, well, if we're doing that many implants in there, I do FAs all day long. I know exactly how much. I can give you an estimate right now. It's going to cost around $45,000. But if you do a bridge, it's going to cost around $30,000. Plus, she's going to have it so much faster. So we're discussing that in front of her because I'd rather you be present to hear what her barriers are in her questions and in her concerns, so that together we can decide on a plan before you walk out of the room. That makes acceptance cake for me.
Yeah. Yeah.
So she knew what the estimate was, and I was high on my estimates. I'd rather be high while you're in there than when I'm by myself. And she picked what she wants. I want to have the bridge. I want to have it fast. Okay, let's go on ahead and see if we can make that work. So that's what we did.
That's right. And then her mother was in the treatment room, or was in the financial arrangements room with her.
Yep.
And her mother?
Yes. You're going to say it?
No, I'm not going to say the whole thing.
Okay. Well, first, let me just make this comment. You know, we never judge a book by its cover, and we laugh about this so much in our practice because there are so many doctors that have said, I can't market to that area because there's no income.
That's right.
I don't want them coming into my practice because of that area code. And I will tell you, it does not matter. Because we have had bigger cases that have been paid by people that look like they don't have a dollar to their name. And this was one of them. Her profession is a CMA, a certified medical assistant. Okay, right there, no money.
Right.
Plus, she's no longer working because she's applying for Social Security. Probably no home. I mean, there's no money there. So if you're looking at somebody, you wouldn't plan this case for her thinking she doesn't have any money. Mom is coming with her. Mom wants to take care of her. Mom happened to win a lawsuit for a lot of money. They looked like they didn't have money. They didn't look like they had money. We're in the financial room, and it's a closed door. We have closed doors. Mom pulls a sock out of her bra.
You said it, not me.
With tens of thousands of dollars in it. So you just never know. People we have had that have had similar professions have left and taken loans from friends, sold boats, maxed out a credit card, took a loan, called family, which that one lady called family that she hadn't seen in 30 years.
That's right, in Arizona, who paid for upper and lower full arch prosthesis.
$50,000. If you work with these patients, they find the money. It's amazing. So don't ever think about that. That's the last thing we say so many times. Don't let money and insurance determine treatment for your patients. If you do it, they're going to do it. So we never do that. So yes, they paid.
That's right. My mom still needs treatment, and the sister still needs treatment. So
yes. She's got more money than that sucks. So
that's right.
Okay.
Exactly right. So that's it. If there are any questions, just raise your hand. There are a lot of people on the line. So if there are questions, just let us know. Otherwise, we will see you the week after next, and it'll be on Tuesday night rather than Wednesday.
November 1st.
November 1st. Really, we thank you for being a part of this, and look forward to talking with you again soon.
Thank
Bye-bye.
you.